coordination, the aspects of systems-based practice are really, really important, as much as we struggle to both teach and assess them. I think what's nice about the EPAs, and again, remember they started in Europe and have been adopted elsewhere, is that, they make us think a bit more holistically. So they do connect pretty well. And I think that may be the work over the next 5 to 10 years. And then we need to develop systems using technology to help bring them together in ways that are just honestly more efficient, make sense. And not everybody needs to be an expert, quote, in milestones and EPAs. The best example I can give you is what's happening at the American Board of Pediatrics, where they want to use EPAs as a way to determine eligibility for certification, where they'd have a program director sign off on things that are important within the pediatric domain, 15, 16 of those, such as caring for children who have behavioral health issues, which is a huge issue right now in pediatrics where they're struggling. They have a growing amount of depression and kids who are suffering from mental health issues. And that's an area they really want to focus on. That's an EPA. You need multiple competencies to do that well. And so in that case, how do we build systems to kind of roll up the information to make good judgments on these kind of more holistic activities? I think that's the work in front of us the next 3 to 5 years. But EPAs are only as good as what informs them. And if you don't, if you will, build them properly, so to speak, with the right competencies, then they're not going to be any better than what we have. And then you also have to make the distinction between, are you looking at an EPA for a curricular purpose or using it for assessment? Because if you're looking at it from a curriculum, I would ask you, Jeff, the following question as a general internist. If I'm caring for somebody who has multiple chronic diseases in clinic, which of the 22 subcompetencies we currently have in internal medicine would not apply to caring for that group of patients?
None of them.
Exactly, none of them. Yeah, that's exactly right. So from a curricular perspective, all of them matter a lot. Now, from an assessment perspective, I may want to just target some of the critical ones as long as I'm assessing the other competencies and other areas or experiences. So from that standpoint, that's fine. And so given how important interprofessional teamwork is in caring for patients with chronic disease, maybe I target that one with a multi-source feedback, for example. But that gives you another way of how these two kind of fit together, but also how they're distinct.
So one of the ways, of course, as you know, and why we have this podcast is that at Northwestern, we've always used simulation-based mastery learning and or just mastery learning in general to tackle the milestones and EPA issues. We've had some success at both the graduate level as well as the undergraduate level with that. In fact, even at the CME level, which is a whole different ballgame. Tell me a little bit about your thoughts on how mastery learning and particularly simulation fits in with at least evaluation to determine competency.
From my perspective, in multiple ways. And again, I think Bill McGay, he's said it best when I had a chance to talk to him a couple of years back about this, is that at the end of the day, these should all be mastery-based activities, right? That's the standard. It shouldn't be a variable standard. Wherever you can, you use a mastery-based standard, full stop. And many times now, that needs to start in the sim lab. I think we're getting to a point, Jeff, where it's going to be really hard to justify letting people learn procedures first on patients without starting in the sim lab. I look at your work. I look at the work of Barry Isenberg. I look at, other people's work. And it's like, how can you not start in a sim lab when you show how it translates, if you will, into better patient care? So that's one aspect. Then there's the aspect of the wonderful study that you were so kind to invite me with that was run by Yara around looking at the kind of attainment, if you will, of proficiency in caring for patients with status epilepticus, where we compared, a group of trainees in the Chicago area with how they performed in a simulation for status epilepticus that used, again, a mastery-based standard. And the reality was there was no correlation between their performance in that simulation and what their milestone rating was. And I'd be the first to tell you that I'm not surprised. And I think that's really important type research. There's also something that really struck me in that study that just kind of blew me away, was the number of patients that these learners who had all graduated actually cared for with status. And it was actually quite modest in number. On average, it's about 6 to 8 per learner over a 4-year training program. And so that's another example where, in some respects, we've benefited from the success of drug development, surgical, techniques to reduce or treat epilepsy, which means that our learners are probably over time going to see less and less of this, or they're never going to see, the kind of numbers they would need to attain mastery if they depended on that. And so you can see where these two have to come together. And I'm also thinking about your wonderful study looking at renal dialysis catheter insertion, where, you could train them to mastery, but there was also a bit of a decay curve. And so they had to go back and do some refresher training. And that gets into your CME point. That's probably true for all of us. If I'm just not seeing, this type of presentation or caring for this type of patient on a regular basis, I need booster training. And a mastery-based approach in a sim is really important. The third thing I would say is just the mindset. That anytime we're thinking about whether it be developmental milestone based on competencies, remember, EPAs are developmental too. They're based on supervision. They just have to be attached to a definition. Mastery should be the goal, right? And you've shown in your work at Northwestern, that's attainable.
Yeah, it's definitely attainable in procedural skills. We have had some success in communication skills and advanced cardiac life support. I think when we look at some of the other milestones that are a little more complicated, it may be much harder to do training and evaluation in the sim center. And I guess the real challenge for us is the future of that is how do we, teach things like social determinants of health or professionalism in the sim lab. You can only do so much because they're very complex.
Correct. Yeah, that's where I would argue, and I appreciate you bringing it up, where you're right. There are limits. I mean, all of our assessments sometimes can't get the full way there. Professionalism, interprofessional teamwork, quality and safety is going to depend much more on experiential, type learning, if you will, in the actual clinical environment. And so there we're going to have to embed those kind of measures into the daily work. And we just don't do that right now. We can. You can certainly observe, but that means we've got to prepare faculty what is they should be looking for. It's that shared mental model challenge. And it has to be done iteratively. And it also means it's going to take some time to prepare faculty to be good at picking up, like you said, these more complex skills that are also very interactional and interdependent with others that you're working with in the clinical space.
And our work has highlighted that I think maybe one of the reasons the faculty don't or are unable to do that is because they don't know how to do it themselves. We've seen time and time again that we've had very experienced attendings where we've brought to a simulator, tested them rigorously, and there's a wide variability in their skill to perform, and many don't meet mastery.
Yeah, I think that's really, I think for all of us, Jeff, kind of an uncomfortable truth that we just have to address. And again, it's nothing personal, but this is the reality. We, by the way, have seen the exact same thing in our work in direct observation.
But in the end, when you're the residency program director or the vice dean of education at the medical school, and you need to fill out these forms for an EPA or a milestone, I think, for speaking for ourselves, I think it really helps to have that mastery checklist to show that they met the minimum passing standard. So you know that they've met that minimum competency.
Yeah.
I shouldn't even call it a minimum competency because it's really a maximum competence.
I mean, I just wonder, what if the program directors had your status epilepticus simulation, like say earlier in their training, could that have led to an intervention to make sure that they knew, how to execute all the steps properly? Could that have actually served the limited number of patients they saw? We won't know for sure, but those are the questions I would ask as a PD. Man, I'd really like to have that data earlier. That could have been really helpful.
And fortunately at Northwestern now we're training all of our neurology residents with that curriculum, so they will get that data to help them. And the scary thing is sky's the limit on what you can do and what you should do. So really it's picking and choosing and doing a needs assessment so you can figure out which curriculum you really need to create.
Yeah, you just have to get started sometimes, right? I mean, that's one of my favorite adages from quality is sometimes, or quality improvement, sometimes you just have to get started before you're ready, and you pick the stuff that's, status epilepticus is high risk. and when done poorly is associated with poor outcomes. So it's a great place to start if you're trying to think about, so if I were to choose something, that's, that makes perfect sense, to begin there. I really appreciate all the wonderful work you're all doing at Northwestern. It's a real privilege to be working and learning from you and the whole team there.
Thank you for being a part of this podcast series, and look forward to future collaborations.
Absolutely. Yeah. Take care, everybody.
Thank you for listening today. In future podcasts, we will continue to discuss key aspects of simulation healthcare education with other experts in the field. Bye for now.